Hezron put up request for us to be able to do these presentations, and he approached me last week and asked me if I would take the first bait, and I said it's okay. I will share with you what I have done over the years, and I hope you're able to see my screen. If you're able to, kindly just let me know. You can, huh? So Emmanuel, I use you as a what do you call it? As a test. If you're able to see, then I believe the remaining can see. Humphrey and team can see. But of course, there's one of us who is driving. I'm hoping that he's able to listen to the discussion and keep us going. I just this, and I said maybe I could share a couple of things that have happened across the years. I'm one of the very oldest in these groups, by the way. I in 1999. I don't know how many of you were born by then, but it's okay. It's okay. So I was among the second lot ever of the communication and media technology team that were brought on board. And I have some kind of, I would say, a wealth of experience, maybe. You will decide whether it is a wealth of experience also. But I thought I would share with you something very different, and I didn't want to get into theories of social behavior change communication. That would be very boring, and that will require a class maybe of masters and that kind of thing to be able to sit down and crack the theories. But I wanted to share with you some of the implementation paradigms, or paradigms, depending on how you want to call them, of how I have managed to maneuver some of the assignments I have gotten over time. There were many things I could have shared, many things. But thinking, being Friday and a time like this, I'll just limit myself to specific areas. But first, I want to introduce myself. If you're not able to see me, that's how I look like. I don't have much on myself. I am that simple. And that is my background. I did my BA in communication media. Then I did a certificate course in monitoring and evaluation. Then I have a master's of arts degree. Actually, that one is unfinished. I got into some other interests, including getting out of the country to work in Somali for some time and that kind of thing. So those things really affected my studies there. But of course, when I came back, I decided to switch and I did a master's in development studies. And of course, now I'm a PhD student of development studies. I am actually a candidate as we speak, and I seek for your prayers. I'm a sixth-year PhD student. I seek for your prayers so that I finish it. And I have worked in the areas as listed below, and those have become my interest. Some of the areas that I have been very passionate about is actually in the health sector. So I have done pretty much, let me see, I have done pretty much 15 years in the health sector. And trying out many of these things, as you can see listed on that band. I enjoy discussing matters of African culture, development, politics, economy. Of course, I love fish, I'll tell you for sure. And one of the things I hate is because of the COVID-19, we are just down. Looking at the fatalities that have been caused and the sadness that we have had. But I'm hopeful that as a continent, we will be able to overcome. So that is all about me. If there's something else I've left on the side you want to know, can you let me know? But actually, my experiences will be shared around the health sector and how I've maneuvered through the health sector. So some of the things I want to talk about is getting the right messenger. So I have decided to not talk about the theories, but really break it down content, very simple. And this I will give a case of reaching young lactating, what we call former Nyanza province. And then I will take you through what we call the effort, being effort sensitive, especially when working with people. And two aspects of effort sensitive. I'll talk about the pay for performance. I will give you a case of something in Kilifi. Then I will talk about non-monetary incentives, and that I have something interesting from Kisumu County, especially with the female sex workers. And then I will talk about time sensitive. And of course, that one also gave me assignment somewhere in Kikuyu County and Kiambu County, of course, looking at how to engage. And this was now about male sex workers. You know, the other one was female, this is male sex workers. Then I will talk about location sensitive and some of the assignments that one of the things I had was to promote what we call the PPIUD, that is postpartum IUD, of course, tunaelewa mambo ya family. And we are looking at locations, and this was in multiple places. Then of course, I will talk about sensitive, and of course, this is a case in Homa Bay County, and looking at how we improved behavioral work readiness among young people who have been out of school for long. Then I will talk about engaging adaptive programs and looking at the case of policy and community-based distributors for family planning matters in Westcott County. And the last one is actually something I'm still working on now, and but I will share some of the interesting things. I'm hoping we can have some time for Q&A, and that will be it. So basically 1, 2, 3, 4, 5, 6, 7. I have like about, for each of these, I've just tried to do like a slide each. So basically, when we talk about getting the right messenger, and I want to give you a case of reaching lactating mothers in Western Kenya, I received a call one time from BBC, and there was a connection by somebody who was in Nairobi, and he asked me to if I could join a program that they were doing, and BBC has an arm, a development arm called Development Media International, and they carry out mass media campaign to improve maternal child health then in Nyanza. And I was squarely placed to be in charge of this program, and I had to manage it with a team of 40 people here. And out of 40, I had 30 who are creatives, who are working around dramas, coding and writing scripts and other things. Then I had a management team of the remaining. And the approach actually was to target and improve knowledge and intent, and also what we call intent and reported behavior. Those are two different things. There is intended behavior, there's reported behavior. And one of the things was on breastfeeding, the other was on antenatal care, and the other one was about giving birth in the health facilities, and then managing childhood diseases or diarrhea. In this case, we were very particular about diarrhea. So one of the things that actually happened about young lactating mothers is that they're actually adversely affected, because the breastfeeding, the culture, the process, the liking, the doing it is affected by many things. There's the cultural issues, there's social economic issues. One of the things that actually young mothers told me when I went down there to work with them was the idea that they don't want to breastfeed because it changes the shape of their breast. That is very, very intimate to the person we are trying to reach to do breastfeeding. And of course, you know, when you talk about breastfeeding, we're talking about 6 months. And that really affected access to nutrition, to food, to young children, and therefore they could actually fall many, many things. And when we talk about antenatal care, giving birth in health facility and diarrhea, it really did well. The data there was very good. And you'll see over the presentation time that I'm very particular about data. But I had a big problem with breastfeeding. And all the messages that went out there weren't giving us the good score. And how did I know that? Because we were working with CDC to be able to monitor and do what we call assessments as we keep going. So one time when I sat with my creative team and we thought through, we have a message, yes, and we need to deliver it out there, because we have been delivering messages, but we are not getting our intended results. So we thought through it and we said, why don't we look for someone who can deliver a message in a way that it actually persuades the mother to actually do exclusive breastfeeding? So we came up with something, and interesting enough, this is the messenger we got. And let me know if you're able to hear this.
Gima berno en chathuno mar mama. Nyithindo dwaro mana chathuno mar mama kende. Chakre nyuole nyaka ochop dweche 6. Ok gidwar pi kata chak moro amora. Kaka imedo dhodho nyathini, e kaka chak bende medo ga wuok. Koro, paro kik chandi ni chagi tin.
Hey, I don't know. Here, were you able to hear that?
Clearly, very clearly.
Okay, if it went through, then I can now explain what that is. We actually got a child was 2 years old, to speak. And whatever the child is talking about is telling the mother not to worry, because what they require is the breast milk, and that's the only thing that will actually make them better. And they should not worry that they have little milk or anything will happen. And the child also reassures the mother that milk start breastfeeding, more milk will just for sure come. And the results were just amazing, because we actually got good feedback. And for this case, we actually put the Centers for Disease Control to actually conduct researches as we did our behavioral approaches. There was good recall of breastfeeding message. This particular message was able to be recalled across board with many, many people in Nyanza region. the most improved indicators between the baseline and end line, and when comparing exposed and unexposed person, were two things: care and exclusive breastfeeding that came up very strongly. The next thing was the proportion of men who believed that babies should be exclusively breastfed for the first 6 months, from 66.2% to 90.2%. And among women, we got achievement of 65.3% to 83.3%. And we were very particular about the men, because it was the support that we required on the men to be able to give women and mothers during that time an opportunity to be able to do whatever they were doing in terms of work, but also set aside time to be able to breastfeed. And one thing I love about this program, and what I would say that magic audio did for us, is that we saved lives. And of course, through calculation of life saving, through Lancet Child Survival Series, and we were able to model and see how many of those lives we were able to save that were breastfed. And through breastfeeding, of course, you can see the total lives, deaths that we averted were 1,944 during that time. And you can see exactly what breastfeeding just does to children in terms of saving life. So for this particular case, and I just wanted to bring it up as a single slide, but think through, you have to get the right messenger. You could have the message, but it doesn't necessarily make you the right messenger. But when you get the right messenger, you just pop up things in terms of better returns, better investment, and better everything. So this is one of those paradigms that I wanted to share with you, and I'm hopeful that I've been able to pass it across to you, that you have to work with the right messages, especially when you're designing your behavioral change messages. Okay, I don't know here how we want us to do it. Do we take one or two questions and move to the next, or go all the way to the end and then we do the Q&A?
I believe that the more interactive, the better. If there's somebody who has a question on this, it will be great to explain, because some of the terms and this kind of topic is also a heavy topic, if you may say so. So I would welcome any questions or clarifications as we move on. It would be great.
Okay, thank you so much here for the direction. Maybe we have a minute. Anybody out there who has a question about this? And I hope I was able to deliver it within the shortest time, and you really got the gist of the matter of what we're talking about.
As we wait, Bill, I would like to ask one. So before you settled on the baby, who are some of the messengers that you are, that your creative team are using, and is it the message that was wrong, or was it the messenger, in your opinion?
In my opinion, it was the messenger that had a problem. And one, we engaged older mothers. It was like a mother-to-mother approach. And we also engaged men who actually talked about them feeling okay if their children are breastfed. And we even tried to engage animated like things, like talking about milk, saying how they enjoy being in a child's stomach and that kind of thing. So there was a lot of that kind of messaging that we put, and we actually put other people also to be able to talk on behalf of us to reach the mothers. But all that was not giving us good results. And we had actually reached a saturation point, which actually got us to 66.6, and we were not able to move beyond that stage. But when we just dropped this child's message and we were able to reach mothers, then we moved from 66 to 90, and that was just a score.
Anyone?
Okay, anyone else? All right, I think I will proceed to the next, with your permission. There's a lot of this information. If you want to read more about all this and the program and the kind of effort we put out there and the kind of information we did and the kind of results we got, and for me, it was just nice to share with you one of the figures, which was a figure 9. And for me, at this particular point, excited the fact that I was able to avert deaths, and in thousands. That is what I would say. So there's a link, and maybe after this, you can ask, we'll send you the links, and you could read more about it. So let me go to effort sensitive for performance. And this is a case of mHealth promotion in Kilifi. And of course, now we are using it to promote antenatal care and postnatal care. for those who are out of the sector, I will just say it's basically ensuring that mothers go to hospital before delivery and continue going after delivery, which is important. And put on this assignment, we came up with something called mHealth Mtaani, and it's just basically using mobile phone to be able to reach mothers. And what were the mobile phones doing is we had an algorithm. An algorithm in the mobile phone is basically you move from one stage to another stage to another stage, guided. So we got what we call community health volunteers who were actually reaching out to mothers, and those mothers were mapped. And then once they were mapped, because one of the issues in Kilifi was the idea that ANC was very low, going to hospital during pregnancy was very low, and even after was very low. And when you engage the community of volunteers, even the reporting was low, and we could lose mothers. In terms of we lose mothers, like mothers dying. So what we did, and also children dying. So what we did was we decided we need to track them, but we had to find a way of tracking them that was quite motivating. Therefore, what we did is engage the mobile phone in terms of setting up something like an app in the mobile phone. And this was a way of changing the behavior of the community health volunteers, and of course also targeting to change behaviors of the mothers who are actually expectant and those that have actually delivered. And therefore, what we did is that we mapped them out and knew their location, geolocation, and fed those locations on the mobile phone, and had particular questions that were actually on the mobile phone through an algorithm. When I say an algorithm, I mean you could ask when were you last visited? On this particular date. When are you due? On this particular date. You enter those details, the phone keeps sending reminders even to the community health volunteer or the person who is engaging them that they need to get back to their mother 2 or 3 days before that, or a week before that, just to ensure that they can get to hospital. And if at all they took malaria tablets, and if at all they have been checked, if they're told they have gone for tests and that kind of thing. So it goes like way. And anytime you visit this mother, you keep following up on some of the areas that were not yet done so that you complete it. So the project actually, we actually introduced something called pay for. And we said there's no blanket pay for community health volunteers. They have to work through this. So they were able to collect mobile phones, and also when we use the mobile phone, we were able to pay them depending on the amount of work and effort that were done. So what this actually did is that it increased transparency, and we actually had quality of service also improved. And then there was also recognition for performance. And then it also led to better health outcomes for clients, community health workers were having. So some of the things, and just the love of data, what really says is that we were able to build capacity of community health volunteers up to about that time, 267, to be able to go out there in the villages in Kilifi and really look out for these mothers and get them. And one of the platforms we were using is what we call ComCare. ComCare is a wonderful platform. You can write it on the side or note it so that later on you can visit online and learn more about ComCare. It was quite nice and self-supportive. So this process, what did it do? It also increased hospital deliveries. I remember very well for one particular hospital called Mtwapa Health Center, they had an average of only 11. Because of this system, we increased hospital delivery to 51. That is an addition of 40 that could have actually delivered in the rural places, died because no one was paying attention to them. So what else did it do? It also gave us better monitoring systems, because we were using the phone, we were able to monitor the work that the community health volunteers were doing and the follow-up they were doing at households. And one of the interesting things is through that app, when you're in the household, after talking to the mother, you were supposed to send us a GPS location, which actually proved that you visited the household. What else did we get? We got quality of service, especially for the orphans that were there. And then we could also determine where they are, locate them, and find services to reach them. That was an additional service that we were doing alongside the monitoring of mothers. Then because of the incentives, we got motivated. And the local community health was also got motivated. So we were able to pay them. They were able to see how much they were getting, and looking at it, pegged on the amount of effort that you are making. So one of the paradigms in terms of behavior change is really to think through. One of the things we've talked about there is really the pay for performance. And you have to be very careful about pay for performance, because you also don't want to make sure that you lose the community touch of the community health volunteer from the community themselves, because it's supposed to be a voluntary process. But this was a pilot, and we actually managed to get the Visa firm, the company, to be able to join us to do this. Okay, thank you so much for hearing on this. If there's any question, we could take a minute before we move to the next.
Bill, as we let this in, I would just want to ask that in terms of pay for performance, what's your opinion in terms of its efficacy? Because you've given, sustainability, you've given a caveat that you need to be careful that you don't lose the community and the volunteership, be it when you're dealing with volunteers like community health volunteers, but when you're doing other services, say getting people to take up certain even health services, or take certain, say for example, go and get screened for cancer, go and check, say, family planning. Is there a line where you'd say, this is not, ethical or sustainable? Is there a cons to this, or it's something that I would encourage everybody to pay for performance, especially when we are the thing that was in the group where the principal was giving a student some amount of money is closely related, although not directly. It's where you give money so that people get results. Are there cons to it? Are there caveats? Are there places where it's not appropriate?
Oh, thanks. Sure. I think you have to really consider the legal age. One, for this particular assignment, we had to work with those who can actually legally transact, and of course we're talking about 8 and above. And if you go to those communities, most of the time we have even very young community health volunteers who are just done with school, and you only engage them when you have the legal mandate to engage them in terms of age, and they're able to get the pay. And of course, for this particular project, we didn't have a problem with any legality, because across the country, category of health workers called community health workers or volunteers who get a stipend at the end of the month. So what we did is that is the same stipend that we actually converted to pay for performance. Of course, now what we did was we gave recognitions of certificates and other things on top of what they were getting. It will be illegal for you to someone to come for a check. That is what I will tell you. You can't pay anybody to come for any checkup. That is quite illegal, and it can't even be sustainable. So basically, that is how I'll respond to your question. Mm-hmm. Okay, do we have any other? Okay, if we don't have, okay. Do I proceed? The next one I want to share with you is equally what we call, by the way, I have a link down there which has got massive content on this particular program and how we managed to maneuver through, and what are some of the things we actually leveraged on. You can actually get online and get, and if you want this particular approach, you can get me on the side. I can send you a lot of literature around it. The other one is about effort sensitive also, but this is non-monetary incentives. And this is now with sex workers. This world is interesting. If you have never been to this world, I mean, basically you might want to visit some of these places, not to do anything other than just knowing what happens. Huh? So don't misquote me. When I got into this assignment and I was told that we have sex workers, and one of the things they want them to do is to be able to get them to what they call a drop-in center. A drop-in center is a specialized kind of a place located anywhere within a hyper place. It could be first floor of a building somewhere, kind of hyper, or somewhere that has got what we call the hotspots. Hotspots are basically I would say pubs, hotels, places where you actually find sex workers hanging out. Those becomes a hotspot. And a drop center, famously now known as DISC, is basically a place where you go and it's like a clinic for sex workers. When they are feeling sick, they want to get checked up and get information, and they can be, helped in matters of violence and that kind of thing, so that they feel free to get there. And they tests, not just HIV, but they can also do cancer screening, many other things, and get advice even on many other things. So Linkage's project since closed, but one of the things they really wanted and the challenge they were facing was the mobilization. How do they expand what we call peer mobilization? When I talk about expanding peer mobilization, let me first of all define what I mean by peer. Now, in the program setup, when they say peer, they talk about sex worker to another sex worker. Those are peers, and they know each other. So Linkage's project had really gone out to mobilize, to inform, to educate many of them, but now they needed to have a behavioral approach where they could expand their peer mobilization. They had reached saturation, and therefore they wanted a way to encourage sex workers to be able to access and make use of the drop-in centers that they had created, and also getting peers to test. So when you get your peer to test, that means you encourage another sex worker to come and test. So this thing was put on my table, and we had to think through. And one of the things we said is that we need what we call a peer educator. So a peer educator becomes a sex worker who is highly informed. We put them in a classroom setup and teach them a lot about stuff, so that they become our eye out there to be able to disseminate information and then continue with that interaction. So we actually designed, and this was squarely on a few guys who are to really think through this, what we call a monetary incentive base, and we call it a sex workers virtual currency. So imagine you using your mobile phone, and what motivates you to play a game over and over and over and over and over is because of the points you get. So thinking about the points that you get in the games you play on the phone, we transfer that kind of approach to how then we can use that to mobilize other people. So we call it the sex worker virtual currency, and to use it to motivate peer educators, the ones, remember, peer educators are the ones we had trained, highly trained, to reach other peers in their cohort. The sex world is an interesting world. Huh? I will tell you that they know where they are, they know where they hang out. So if you are somewhere in Nairobi West, you get one sex worker, she actually knows the remaining sex workers who hang out there. So we get one who is really stationed in Nairobi West, we take her to a classroom setup, we teach her so that she's highly informed on matters of HIV, matters of testing, matters of cancer, matters of health, what happens at the DIC, and why it is a good place to go. So once we did that, we actually released them to go back to their what they call the drop-in centers. So we had an initial test of this, and yeah, this is not very far from where I think so. We did something in Kisumu and the famous Kondele in Kisumu. So there's a drop-in center around there, and anybody who is there who wants to know where they are. And by the way, I have locations of almost all drop-in centers in this country, all the way from Lodwar, Turkana, on the other end, Lisa to Mombasa, back to Migori. If you want to interact with a drop-in center, you let me know your location, you'll be able to see and visit one. So this was the architecture for what we call the sex virtual currency. We put them in different, looks like a mobile phone game, but now we have to play it in real life out there with things. So you go through level 1, which is a social behavior change level, where the peer educators are the peer educators so that they can get messages through bulk SMS. So when one sex worker accepts to register, the peer educator gets a point. Now, here, there's a ratio of 1 peer educator to 80 peers, depending on locations. Some places will go down to 40, but will stretch up to 80. And then, so if you registered 80 people, you'll get 80 points. Then those that you have registered will continue receiving messages every week, continue getting points. Now, when they get that level, then you have time to talk to them. It could be 1 month, 2 months, 3 months. Then you move them up to level 2. So you have people you have put, 40 people in level 1, then you move them to level 2. Now we want to make sure that you are the one, as a sex worker, talk to your fellow sex workers to test. So they will actually get tested DIC or during what you call an outreach, you get a point. Then they have to retest after 3 months and another 3 months. So every time they retest, you get a point. Then once we realize that those ones were being retested have become comfortable with the DIC, we move them to what we call economic empowerment. So then we have what we call savings and loaning association. So these are chamas, the chamas that you have out there, we ensure that they created them at the DIC levels. And then from that point, we also now push them with the money that they got to register for NHIF. Then they will be moved to level 4. Now the person who moves to level 4 are not the ones that have been recruited, but our peer educator who has been doing the good job. And now we say, you have been doing this job for 8 months, 9 months, these are the points you have. So if you have 800 points and above, they qualified for a trip. And in this case, they actually proposed they wanted to go to Mombasa. And we took the ones who got 3 of them who got the point to Mombasa. And then the ones who got 700 and below got shopping voucher. And the ones who actually got 600, they qualified for a fun day. We told them to come with their children and we organized a fun day. So out of all this effort, what really did we get? I had 21 peer educators who were actually doing all this game playing and working out through this behavioral plan. And through this period, we had a target of 1,748 female sex workers within the cohort, but we managed to register 1,487 and to enroll them in the system, and they have been receiving information. We got 1,099, 62% of them just for the very first time within that year that had not actually tested. They had evaded the loop for testing. And of course, I only got about 19 people who were interested in joining NHIF. There were a few complications here and there. They felt it was expensive and they felt but those who joined really felt it went very well. So overall, there was 14% increase in the number of sex workers reached with HIV prevention messages. It crossed the board that we got. So this is one of those non-monetary designs. I checked with the DIC when Hezron asked me to, oh, by the way, I presented this in the AIDS 2018 conference. And last week, Hezron, for your case, I checked with the DIC just to find out if they keep sending messages. And this message was sent on 16th of April, and they shared with me a screenshot of the messages that they sent out. And that is something that is still working till now. And they use this model. I want to stop there. If there are any questions, I'll pick concerns, answers, and then we move to the next.
Any reactions? If somebody wants more clarifications, and as you do that, I've just shared a link of the.
Okay, I can see Otieno Ahmad has raised his hand.
Please go ahead. Otieno Arnold, Karibu.
Otieno, kindly. Yes.
All right, thanks Bill for this, and I'm personally interested in this because these are people I work with every day. So I'm particularly interested in the architecture, and you say that it's kind of a game. So I was wondering, was it how are they doing this? Was it an application put on their phone, or the architecture was kind of a game, but in real life it was still paperwork where they would have, let's say, the peer educators organize a meeting and they're given some sheets. They record the names of those who would like to be in the campaign. How was it done? The second one will be, I'm also particularly interested on the NHIF, and only 1% of the total population registered for NHIF. Was this a concern, and how did you go about this, ensuring that more enroll in terms of maybe looking for funding to ensure they enroll, or checking on the level 4, the fun one, converting those points to NHIF registration kind of stuff. So those will be my comments.
Okay, thank you so much, Arnold. Number one, we actually had to do a management for this. The other bit I've not talked about is the management for this. Agree with the DIC, who is going to manage what we call the logs. The logs basically are all the scores that each of the 19 are getting. So what we did is just got to computer, made it very simple for the sex workers and the managers on the place, and they open an Excel sheet. And everybody who is getting people to register, they actually come every Monday and say, okay, I've gotten 3 people I've added onto my system. Kindly add my points. And then with the documentation of how many in the system. So as much as the game was going out there, there were people who were managing the entries and really making sure that we don't have anybody who is stealing, quote unquote, additional points without evidence or that kind of thing. So everything was actually managed. If you got a sex worker to get tested for HIV, then we would get your feedback from the person who is doing the testing and say, okay, so-and-so Arnold bought 3 girls and the girls have been tested, and so give Arnold the point. So there's a way that was actually managed. For NHIF, the issue here with sex workers is that they don't want money leaving their purses. That is a big issue. And that's why it became a little difficult to get most of them registered. In the beginning, I thought I would do like about 1,000 people on NHIF, but the payment of 500 shillings per month is a challenge to many, many sex workers, especially if that is exactly to make in a day. And Arnold, I will tell you, the price of sex really differs across board. Right now in Kisumu, I don't know, because of the situation and COVID, you will be getting around at, depending on where you are also. But you see the kind of sex workers we are targeting are those that are actually highly vulnerable. And therefore the rounds there will go for about 20 shillings per round. But there are times when they go for 50 shillings per round. So if the round is 200, then she only needs 2 clients to be able to get to 500 or 400 in a day. But if the rounds are 50 bob for short, then she needs more clients throughout the week. So they say it is a little expensive to try to maintain the payment of NHIF. So the ones that we put there were the ones who were able to say, okay, we are trying it out. So we only got 19 who were interested in that, and they did that. So one of the things we also did, got an officer from NHIF to come and talk about NHIF to these girls, and it was eye-opening to many. That's how we even got 19 registered. Now, the point in terms of translating the points, it is one girl who is a peer educator, and the ratio is 80, and therefore, if you bring of them to get messages, you get 8 points. And every time a message goes to the 80, you get another 80 points. So it was very easy for them to accumulate the numbers. So what happens is that at the end of the day, we will measure how many of those points do you have or delivered. And then, of course, you will get the points. I mean, you will get level 4 fun. Now, the level 4 fun is hidden from other sex workers. Sex workers who are being mobilized do not know that we have a game. We are playing. But we are using this for behavioral so that we get peer educators who are sex workers who have never been out there to do something. Because Arnold, yourself and myself are not known to those girls. Unless we want services from them, they will not want to engage with you in anything else. So we had to get people to work with. So for us, that's how we approached it. Welcome. I can see Vincent's hand is up.
Go on.
Hello, good afternoon. Can you hear me?
Very well.
Hello.
Yes, Vincent, we can hear you.
Can you hear me?
Very well.
I can hear you very well.
Okay, thank you very much. Okay, thank you very much. I wanted to ask, how sustainable is this strategy in terms of, let's say, if the incentives, let's say, perhaps I'm thinking maybe it's donor funded and maybe there are no funds or something like that. Will it continue without the incentives as the message is sunk on them that they actually need to be doing this test and going and getting an HIF, something like that? Or it's just the incentive that is pulling them to this? Without the incentives, will it continue?
Okay, So maybe just to make clarification and ensure that we are on the same page, Aditi Vincent, the incentives are only meant for the 21 peer educators, the one that we put in the classroom setup to help us break the ceiling that we had reached in terms of saturation. Remember, the project has reached a saturation. They could not recruit more, but they needed to get more numbers who are actually out there, because the mapping that was done in that area indicated that there were more out there than the ones they were reaching. So this strategy actually helped us break the ceiling, the saturation ceiling, so that we're able to stretch an additional one. So I checked with them. It's a project I've since left. I checked with them last week. I wanted to know how they were faring on. And they told me some of what they have done is that they have just changed their awards, so that if at all there is something they cannot afford, then they cannot be able to do it. Fortunately for now, just fortunately for now, these programs are being managed by some donors who came in and took up, so they can still continue doing it. Maybe, as you say, Adede, we should now think of more fund levels that are more sustainable, because any other thing on level 1, 2, and 3 is actually sustainable, including the message that they actually sent on 16th of April, which I insisted that share with me so that I share it with you. Thank you so much, Adede.
Okay, Karim, asante.
Welcome. Okay. I will say continue to the next. Okay. So I want to talk about what did it say? This is time sensitive. Time sensitive is very important. And sorry, guys, a lot of these examples I'm giving with the sex workers, because they are a critical population. Sometimes it can be difficult to work with. And they're also a good area for discussion, because you could have an area you're working in and you're doing stuff you're doing with people, but you really don't know how to engage the team. So it could be one of those that you can use for learning. So basically, one of the things that happened, because we are talking about male sex workers, you know, the other one was female, now male, and this becomes very sensitive, by the way, can become very, very sensitive depending on that. But of course, this also had the female sex workers on it, but there was a little component on male. The idea was about the hours of service. So when we talk about behavioral change, you are thinking about time sensitive. How sensitive are you to people's time? So one of the things we did was to look at how do we then operate with time. And there was concern about the hours of operation of the drop-in center, because when I did my baseline and I did my assessment before intervention, because that's what you do an assessment before you really bring up a behavioral change intervention, I discovered that the hours of operation were like office hours, and I told them it can't work like this. We have sex workers who are operating from different line rules, and they cannot operate as if you are operating in office. So we decided to do what we call an extended hour, and the extended hour will start from 6 p.m. to 10 p.m., making additional 5 hours, especially for the one in Kikuyu drop-in centers. And then to ensure that there was good turnout, we actually also ensured that we had the people required. We had the coordinator, person in charge of the facility. We had the M&D person who would really help us with the data man. We had a clinician, everybody that you want. You walk into the place, it looks like you're walking in during the day. And of course, the services, we ensure that all constant services remain constant throughout the time. So what we discovered over time is that in the morning hours, from when you wake up all the way up to 10, 11, they are not coming to the facility. So we told the staff, why don't you then push these hours the evening, and then in the morning you take your sleep or your nap. So we have compensation time. And they agreed to that. So once we did that, we had more than 20% of all clients increasing services at the drop-in center. And we actually realized there was an election period, so it went down, but after that it continued. And others actually also were able to move around and seek services elsewhere, but there was a 25% increase. And there was the idea that there are people who actually, especially the female ones, who shied away during the day, and accessing times at night, they felt that was okay. So the idea of services offered in a private environment was very nice and confidential. They were actually assured of this. And, you know, the fact that we moved the timing to access the health facility at night, it reduced the transport cost. Because if you put it during the day, you expect the male sex worker or the female sex worker to come to the facility during the day, spend money, go back home, and wait to come out at night for work. So we actually even reduced the cost of operation from their end. And then it also helped because it made it so convenient for other people within the area who were able to bring other sex workers within a kilometer who could just walk to the place. And this actually continued for a period of 4 months, and we were able to reach 1,300 female sex workers who live and work around the place. And I like this graph because this graph just tells you the hours and the extended hours. So you can see how behavior can be changed in terms of health-seeking behavior, and looking at it in terms of time, and then how then do you structure it so that it works for you. Okay, I'm trying to make the presentation a little shorter as we go because of time also. I'm being time sensitive. Any questions on that? Concerns? All right. I guess I will proceed. The next one. So this is basically about an assignment, January to September, and it ran quite some time. And PPIUD is postpartum, IUD ni ile IUD ya family planning. There's nothing new. So postpartum basically unazaa hivi na tunakupea PPIUD. And one of the reasons why these guys were doing it is that they were actually getting some of those mothers that will deliver, and then a year has not elapsed and they have come back, they're pregnant, you know? And some of them even imagine they cannot fall pregnant when that happens, but it happens, you know? So I got myself into this assignment, and I was excited to be part of it. So I worked with COGS, and COGS were very interested in actually ensuring that they institutionalize the immediate postpartum IUD. Immediate here means unazaa hivi na tunaweka mtoto anatoka na the first thing that goes inside after mtoto kutoka ni IUD. It doesn't matter whether you do normal or through cesarean section, but that was placed, and immediately it's placed, then it means you can take like your 3 to 5 years or even 10 years, depending on what you really want. And I had this assignment in 6 national teaching and referral hospitals in Kenya. And I received this call from someone who I think was told that I could try this out. So I worked with COGS, and the idea here was to address the gaps of continuum and maternal health. And of course, we needed to develop a persuasive strategy to communicate to mothers out there. So there were many things that we talked about talking to mothers in person, talked about handbills, talked about outreaches, but we ended up with what we call audiovisuals. And we agreed that these audiovisuals will really help in terms of reducing the proportion of women who leave the health facility without receiving contraception. And of course, that if they're left without it, that would be a missed opportunity. So what did we do? We actually planted the audiovisuals in the MNCH clinics and in the wards. And we did them in all the languages that we could do. And okay, for this case, it was just for English, Luo, Swahili, and Meru. And we tested and refined and had broken. And we put them, for the first time, there were screens in those wards, and the mothers were able to engage with them before delivery. When they came in, they were able to engage with those with the audio that were actually shown to them. And therefore, the facilities used this as a health teaching material. And over time, this actually improved the uptake of postpartum IUD. Unfortunately, I can't show you this data because they tell me they ended. They are working on cleaning their data. Once they have done the cleaning of the data, then we can be able to show the data. For those who don't know what I'm talking about, that is what I'm talking about. And there's a link you can go and read more about it and what we have done with COGS. So this is one of those paradigms that we developed with the COGS team. Okay. Any questions on this?
Yes, I have a question.
Yes,
Yeah, there's a question. There's a question. Yes.
That's Lydia.
Yes, it's Lydia.
Mm-hmm.
So,
Lydia just went off. I can't hear her.
I think she dropped because of network.
Lydia, your mic is muted. Lydia, your mic is muted.
Can you hear me now?
Yes, I can hear you.
Okay, so you're saying that the IUD was planted within 48 hours of birth, and this was consensual?
Yes, it was consensual. It means we prepare you from the time you attend the clinic. We don't ambush you when you are in your back pants and you want to deliver. No, it is all prepared. And therefore, we have videos to show you exactly how it's going before you actually consent, and then you will consent, and that is noted, it's taken down at the facility. When you come to deliver, it is done, and it is actually, you are actually informed immediately after delivery that now we are putting the IUD. And after that, when you're in the recuperating ward, that you take about 48 hours also in the recuperating ward, and you actually watch videos on what we call counseling for continuity, how it's gonna be, what are some of the things you need to now know about it, and more, and also you get additional content on other family planning methods. So it's actually a continuum of delivering health messaging.
Okay, and this was a decision that the mother was making by herself?
This was a decision that the mother was making. No one is coercing, and it is illegal to coerce.
No, I get that, but then there's also that dynamic of the father of the child and some objecting to a contraceptive, yada yada.
Yes, I get your point. Unfortunately for this presentation, there's a lot I've left out that I could have shared with you. I thought the highlights would be good, but I get the point. One of the things that was happening is that there was the co-agreement that yes, I'm okay with this. So in one of those visits in the ANC, the expectant mother would be asked to come with a partner, and then the part and parcel of the consenting process. The audio visuals that we also made really supported the partner consenting. And if you're okay, I'll share with you one of those later on using some links so that you can watch some of those audio visuals that we created. And whatever you raise is very, very important, because as we speak right now, a case somewhere in Narok East where a man took a spear and cut off the two, the two rods, the two rods, just cut from the mama somewhere in Masaini. I have a case I'm handling now as we speak. And therefore, if you don't involve their partners, then it becomes very risky. And therefore, we are thinking of different models for family planning in that region. Just for the sake, because you asked, of course, it's not going to be part of this presentation, but because you asked, right now, I have changed the behavior model for family planning seeking in Narok East. What I'm doing there is that now we are doing what we call children clinics. Now, when we say children clinics, the men in Narok East, the Maasai, do not want to attend those clinics because it's meant for children. And therefore, women and children are graded at the same level. So when the child is brought for immunization or for checkup, the mother is immediately given an injection of choice. That means that you cannot touch her body and find where the injection was administered.
Okay.
I hope that was helpful. So in addition to the content, yeah. So those are some of the things I'm doing now. Once I have good results in future, if Hezron feels I can have another second sharing, there'll be a different lot of another almost 15 things that we can talk about.
Okay, my last question, which has been partly answered by the developments in Narok, but then why the IUD?
COGS got funding. COGS got funding for IUD, so they were interested in having the IUD out there. That is one. Number two, IUD is long acting as opposed to others, which is better off for this. So when a mother actually has delivered, most of the time it is expected that we're talking about three and above years before we see another delivery come up. That gives the mother enough time to heal actually and to recuperate, the systems to get better. So IUD gives a good option.
Okay, okay, maybe I can Google that. What is the favorite?
Failure rate very low, very low. I think one of the things that happens with IUD, which is good, is that anytime you come to the clinic on postnatal, your IUD can be checked if it is in place, and that increases the rate for performance.
I see.
Yeah.
Right then. Okay.
I will encourage you, if you want to know more about IUD, you can go online, read about. If you are in any of these places, if you are in Kisumu, the district hospital, I know the person who is doing this there. Yeah, that's now the sub-county. If you are in Mbagathi, if you are in Thika, if you are in Mombasa, if you are in Embu, I can give a call and you can get to know more.
Okay, thank you so much.
All right, Bill, I also have a question closely related. Since this was about location sensitive, and you mentioned that you had 6 targeted locations where you had this multimedia in. So I just wanted to know if probably you could say most of them are visual or audio, and then which were these places? Because when you talked about pregnant women, immediately I thought that in the labor ward, and in their concentration in inakuwa kidogo sana. So, and you alluded that ilianza from kitambo mapema. So maybe you could just talk about the locations that you put them, where you concentrated most, and probably were most of the material audio or visual, or it was a combination of it. Was it assisted, or was it only via, say, the TV that is there, or the speaker, or did we have people probably showing some visual things or their posters? Just break it down so that.
Okay, we had audiovisual, which had what you call the teaching plan. The teaching plan was a supportive document that was given to health workers so that they'd be able to answer the questions that mothers would ask when they were at the ANC. MNCH, maternal child health. So before the delivery, mothers have got to go to clinic. When they go to clinic, they get what we call the health talks. So we replaced some of those health talks with some of this information that we have. So the video will be shown, and when they're being shown, everybody is shown. They wait for a team of about 20 to 25. They watch the video. They have discussions with the health worker who actually now answers the question. So that is how it was done. Now, that is at the clinic, before delivery. After delivery, of course, at the labor ward, you cannot have the video. I don't know whether you have been at the labor ward, but I have been there several times on many other occasions, I will tell you. And even just to document some of the things that happen, it's a chaotic place. No one is concentrating on anything apart from the mother and the child who needs to come out alive. So that will not be the best location. The next location was after delivery. So we call the delivery, for let's say the restrooms, where you after deliver you can go and now rest and now relax, and therefore mothers are about 48 hours before they left to go home to ensure that we don't have any hemorrhage. Hemorrhage is basically just bleeding after delivery, which is very. So during that time, when they're still at the facility, then they will call the continuity for use. So we have the that happens at that point.
Thank you.
Okay, thank you so much. Allow me to go to the next. And the next about retooling. So I'm on this assignment, and we have very many young people out there. And some of them actually are orphans. Actually, most of them were orphans, apart from one who maybe had an issue and was out of school. So we needed to work on something so that we get the young people back to doing a few things. So this was about improving behavioral work readiness, because you have this young man in the village and you really want them to get something to do. And we have talked to a couple of other places who can absorb them, but they are not ready to be absorbed. So what are some of the things that we were able to do? One, we were able to come up with a module, and this was for training out of school young people for real workplace scenarios. And some of the things, personal grooming, managing self during coaching and OJT period, and also how do you apply for jobs, conducting mock interviews with discussions and interview questions, and developing curriculum vitae, simple things, tasks like email and the rest. And this was a 9-step kind of thing, quite detailed, and it had 3 objectives. One was to ensure disadvantaged and OVC actually learn and acquire life skills, relevant job market skills, saving education, small business training within 3 months. And this was an intensive training that we did within 3 months. And then what we did is that we facilitated these people to get internship. So you can imagine us going to the village, picking those who are just seated there, and we're saying, young man, you are an OVC, are you 18 to 25 years? Come and accept to go through months. And then after 3 months, we can see what we can do with you. And out there. Then the other thing that we did is to ensure that that the orphans actually were able to receive vital pre and placement advice on how to go about. So for this assignment, we actually recruited 472 young people on this kind of behavioral approach. And we put them in training during that time. There were 172 who were continuing with sessions. Of course, you know what happens in a rural setup with people in the rural setup. People have not been in school. Maybe they have to be off for 1 week to attend something, to attend to their children, to do something. That is quite normal, to go to the farm and do something. And during that time, we actually had 255 who completed the training, and we had 45 who dropped. And of course, the dropout rates were also there, and there were other factors leading to dropout rates. So we concentrated on the ones who completed. And what did we do? We managed to secure 244 spaces for internship spaces for 244, and we got direct jobs for 4, which was quite good. And we didn't just get it because they did their work to get it. They actually went through the training, and we packaged them, repackaging basically. And in this case, I'm talking about retooling because they didn't have the skills. So we gave them the skills, and they were able to go out when they were behavior ready for jobs that were. Basically, these jobs cut across the small jobs that we have: a receptionist in a hotel, somebody who's joining the cooking team in the kitchen, a lady got a job in the welding farm to do many other things that are there. So, and for that interest in terms of what they had learned and the institutions we had put them, 3 of them actually decided to further their studies in particular areas. So of course we had 4 who were well during that period, and of course we had people also on care and treatment. And this actually gave us a very good view of how then you can actually retool young people out there. And you can imagine you got 472 people who are not doing anything back to doing something, to try. Finally, we end with, I think now some of them must have been out there getting things that they can get. And of course, this was a concept that we presented in the first SBCC conference that was actually supported by the Population Services of Kenya. And this was a thing for us. Thank you so much for listening. Any questions on this? Okay. Anyone?
Okay, just out of curiosity, was
Yes.
this part of the Dreams Innovation Challenge, the one that was funded by, was it PEFA, USAID, and Gates?
No. This was part of Mwendo.
Oh, okay.
By USAID.
All right.
Yeah. So we work with young people because one of the things we're doing is to being able to there was something, if you have worked in these programs, let me just explain something in less than a minute. When young people who are orphans are recruited to these programs, they are worked through so that they end up with what we call graduation. Graduation means that as a young person, when you get to 18, you're supposed to be left now to continue with your life as the program gets an opportunity to recruit other young people to help. Now, one of the reasons why we came up with this is because we realized at the point of graduation, you discover an orphan and vulnerable young person who now ceases to become a child, now begins to become a youth, does not have a place to go, and they fall vulnerable for other things. One, they will get into stealing, they'll get into sex work, they'll get into all sorts of things. So we had to rethink, how then do we change their thinking, and how then do we prepare them to move forward? So we looked for those young people who are now between age of 18 to 25, who have actually been graduated, and introduce this program to them so that we can empower them as they continue.
I have a question.
Yes.
How long did this program run?
The training, okay. The training, this particular approach of retooling young people and improving behavioral readiness, the training takes 3 months.
I see.
Yeah, this is 3 months. And I will tell you why. Sometimes you have, most of the times the designs were half day because young people have to walk from where their homes are to the training center. And of course, we also have young mothers with this. who have to go home in good time to take care of the children. The other bit is that some of these houses were actually child-headed houses or youth-headed households who have got other things they're doing on the side that they're trying to make a little money here and then to be able to take care of their children. So you can say if we're talking about a full-time thing, maybe it could be about a month, but because of these other factors, it will take 3 months.
Okay, these other factors, is it something that this is what you got to know during the baseline, right?
Yes, for all the sharing I'm doing in terms of SBCC, all these other factors were actually discovered at the baseline. And basically when we were talking and looking at even the training modules and looking at how content can be delivered and working with experts in terms of content delivery, we even engaged guys from the KICD to think through what are we talking about? How long should this take and adequately how? So this was what advised the training to take 3 months, the baseline, yes.
Understood.
Sorry, I am not able to crowd all this single slide with every little detail. Happy that your question now opens up the other part that was hidden in the slide. Thank you so much.
Frank has his answer.
Maybe just a general question. Can you hear me?
Yes, I can hear you.
So in the area of BCC,
yeah,
assuming now you stop now sending messages, how does the behavior look like? Do they go back to the routine ways of doing things, adopt the pattern that has been created by the messaging? How does it look like?
I left out one of those presentations. Hezron, I guess that is Hezron. I can see that activation is on you. I left out a presentation to talk about how behavior now is manipulated using mHealth. And mHealth, basically, I'll tell you, define it as sending messages. I left it out, but I will just answer your question. But as much as it's not part of this, and this here for these young people was not to send the messages, but there are other things that we have used in terms of mHealth to send messages. And one thing we have learned over time, that messages have to be very, very accurate in terms of short, in terms of, and timely in terms of. And the other thing you also need to note is that we have people who are crowding messages to young people who don't want messages. There are aspects in terms of mHealth and how you can apply it to ensure that you do not do what we call saturate their phones with many things. And of course, you as an individual, you actually get tired when you have to receive 20 messages from Safaricom in one day or Airtel. There is also a saturation point that actually works. Then something I've also learned over time is that messages on mobile phones do not necessarily change behavior. They need supportive environment. For example, if you tell a young person that if you discover that you have a swelling on your private part, you actually could be suffering from 1, 2, 3, and therefore you need to be checked up. But we have a problem when you're seated in Nairobi, Hezron, and you're punching in a message through application on your laptop to send a message to a young person in Kitui that this could be the issue, but the young person in Kitui does not have what we call supportive environment to move from their home to go to a health facility and say, I have come because of this. So there's a lot of work that needs to be done so that messages can actually enable behavior change. You need to get the young person who has a phone that they can access. You need to is right, accurate, short, to the point, clear, concise. You need to get a health facility that you can work with that is ready to receive this young person within what we call a youth-friendly environment. Because some of our facilities, and I'll tell you for sure, we have done the studies, you go to those places and the nurse will keep shouting, wapile kijana anasikia vibaya kwa penisi yake, kuja hapa. And that then sends the boy away. So there's a lot in terms of behavior. So there is what we call the triggered behavior, where the young boy and know where the facility is. It is hoped that next time when they see a swelling, they should actually go comfortably to the health facility and get tested and treated. But that is not automatic unless there's a facilitative environment. Thank you so much, Hezron. Next time, we could have a session that is quite different on how to manipulate technology and how that actually affects behavioral change.
Right, Bill, Frank,
thank you, Bill.
Hand up.
Okay, we proceed.
Frank has his hand up, Bill. Maybe.
Oh, Frank. Oh, yeah. Sorry. Yes, Frank.
Yes, Bill.
Yes.
Thank Thank you very much for this presentation. Now, I'm sorry I didn't join at the very beginning, but I was able to join in when you were discussing the bit of the mothers, and now this one on the youth. Yeah. It's interested in this because I have a number of boys down in the village whom I thought could take advantage of this program, and I wanted to know your criteria of picking these youth and when the next program is going to be. But from what you've explained, I'm like yours is a very straightforward kind of thing, and you say it can take a month, but you're pushing it to 3 months because of those other intervening issues. A typical case, like if I would want to take advantage of this, I would be looking at people who are really into those behaviors like drugs, alcohol, and those kind of things. And how do you deal when it comes to those kind of situations?
Thank you, Frank. One, I will tell you that since I did my assignment for this project and I since left, I went and joined other things and did other things. Frank, the world of behavior change communication is so exciting that when you're done with one project, you really want to jump to the next one and what is the challenging thing. So I really want a challenge. If someone needs the challenge, more challenge than what I'm getting now, I'll jump. And so these are some of the things that I've done. One, I will tell you that if you have young people, maybe place or somewhere or estate where you stay, this is something you can share with the team of people estate and agree with them that you don't need to take 3 months, agree on what are some of them maybe have university training and that kind of thing. We don't know. The ones we were handling were those that had just done Form 4, and some were actually just done, and that was it. They were years after class 8. Some have been home for 4 years after Form 4. So the levels are very different. And therefore, this is a model you can apply anywhere you want to apply. You can apply it in your rural home. You can apply it in town. Just make sure that you get a group of people that you are able to prepare. The thing that this, because of time and the slide crowd, is that ahead of preparing these young people are not like you used to be. Today, young person really wants things done. So you cannot promise the young person you're going to teach them and you don't have a place. So we actually many hotels in Kisumu town, in Mobi town, and asked them if they were able just to take just one come in and do something for about 3 months, and that was it. So it was not hotels, we went to garages, we went to places that people are doing businesses. So we were able to map out for the opportunities we have 200 that we can put in hospitals, we have 200 that put in hotels, we have 50 that you can put in a garage, you have 300 that you can put in this, so that when you go out to mobilize young people, you already know exactly where you're going to place them. One of the problems you will encounter with behavior change is if you prepare people the job with, then that means you will have killed the program. So you really need to figure out how then you plan. You plan ahead of time. So if you have young people who are, and you want them to play, they are boys, they will also be interested. It will be amazing for you to find out they're interested in hair salon work. You look for a place where they can get treatment for 3 months after being trained on how to work. And then they're exposed in those places. Time they gain interest and they continue building up. You could also get girls who could get to mechanical things and they get interest to build that one. Girl to date, time I go to Kisumu, a couple of things on my work. She's one of those who actually went through this program. So I really sometimes give her an opportunity. She does now wiring. She checks a few things here and there, and it's quite excellent. Next program, where programs have been awarded, West, something like that. PATH, Program for Appropriate Technology in Health, will take over Homa Bay and that kind of thing. So if you have people in this region, now they will go out to scout and recruit them. And obviously are not just recruited that way, that is created out. It will take too much time for me to explain here. It's something I can send you on the side. Thank you. Okay, if they don't have any more, can we proceed as we go towards the end? Okay. So now I want to take you through something. This is called adaptive learning. Challenge. Change. Interesting way. You see, seated somewhere to work on a document, but I'm trying to tell the government that we need change on how we engage our people down there. And therefore, it is possible that we can change on the engagement. So I'm looking at the case of policy. Working communities, I mean, go all the way to Board of Kenya and Tanzania, I mean, Board of Kenya and Uganda, and then look at what is working and what's not working, and discuss with communities there what we can do for what is working and what's not working. And now using the learning, what you call adaptive learning. On the left side of the screen, you can see some of the areas I'm talking about. And we are looking at adaptive management in terms of collaboration and asking right questions, management, adaptive learning in terms of learning itself and asking those particular questions. And we are looking at in terms of adapting and in terms of enabling environment. And this community is one community that was cut out and completely cut off from many, many things that are happening across in terms of family planning. And therefore the interest was to get them back. And therefore, waiting for them to go to the facility through terrains that are not working is not the best. So we had to think through, what do we do? So we came up with this design. Of course, that region is doing badly in terms of family planning. The rates are very low, and things are not very nice there. And of course, we have marginalized people, and the effort here is to ensure that these women and girls can get safe family planning and they can plan their pregnancy, and their rights are also observed. And especially my target here is the rural, marginalized, and persons with disability. And of course, now what we did, the model here is almost similar to what I have just explained in terms of what we did in terms of improving work readiness, but this is more of specialized kind of training. So we picked community volunteers, the mamas who are in the village, who do not know much of your work in Nairobi, but they can speak some English and that kind of stuff. And at least they have reached out because that was the target we wanted. And we took them through a training that was very important and before certification. And therefore we trained them and they had graduated. And we worked with communities. Now you can see where behavioral change is very interesting. We asked communities, which mamas in this village do you think can support you in terms of health? And they actually pointed out and said, oh, Mama so-and-so is good, Mama so-and-so is good, work with Mama so-and-so. So the selection was at community level. And then we told them they are going to, what do you call it, the main town in West Pokot, and they're going to be trained in a facility. And then they took the 3 weeks training, which was quite rigorous, including attachments at a hard facility. So at the end of the day, we discovered that we had a strong foundation of community engagement and accountability, which came from an open community recruitment process. So as opposed to hiding in to recruit and imagining working with the normal people we've been working with, we are now recruiting persons that we can actually make sure that community hold them accountable of what they're doing. And then we also realized that they were actually recognized because there were people who were known. And what else was important was that the men in the community also gave them respect. And in this case, we do not just pick men only, I mean females only for this assignment. We also picked men, and then they have actually picked up the trade, and they're able to deliver information services and products to the community at the community level. Some of these products are actually injectable, DMPA. You just come in and you get an injection of it. The Cyana Press, if you have heard out there, those are very nice products that actually are administrable at the community level. The other thing that has been good is that now, when I checked with them, because we did this in November 2020 to January 2021, this is one of those latest things I'm very excited about, because you can see the number of methods that people received, 84% out of the, you see the number there? The N is 986. These are people who have never been reached with family planning methods. All of a sudden now I have 986 women of reproductive age who actually 15.2% got referrals, because there are those cases that actually have to be referred to link facilities, what we call the link facilities. So if you work in Kingeret area is a sub-county there, so you have a Kingeret sub-county facility, you actually go to that particular one. And then we had also messages that were delivered to the females and males, and these people were able to deliver messages in their churches, in their mosques, where they are seated, and they will record how many people they will actually be able to reach. For the first time, I'm opening up that area, which is quite interesting. And I have very interesting results, which are still going on. For the first time, you can see injectables just skyrocketed because everybody was comfortable with it. IUCD, you can see the numbers of the implants, oral pills, the condoms. And of course, we still have some people who believe in the natural family planning method, which is just okay with them. So basically what I'm telling you is that now I am using what we call the adaptive learning method. And I'm presenting this case to West Pokot. We have already written a technical paper for this, and we're asking the county to support this model for the remaining parts that are actually hard to reach geographically. So this, up to this level, is the kind of results I can share with you. Any question? Comments, suggestions, thoughts? Adaptive learning, as you think through about asking questions, I would challenge all of us to start thinking about adaptive learning. That is the next big thing out here, adaptive learning. And the persons who can do adaptive learning best are communications guys, because adaptive learning really relies on documentation and being able to tell a story very well, being able to engage and connect. Very, very important. But of course, you also have to sharpen your skills in the area of data. Okay, any questions on that point?
Yes, Bill, I have a comment, and just like to say
Yes.
that this is really great, and like we said in the beginning, I think this presentation is heavy, and it's heavy because it's talking about each and every slide. It's talking about an area of practice in communications that can actually be a presentation of its own. So I want to appreciate this, and I want to take it as an icebreaker. And in the spirit of adaptive learning, I was just thinking if we could also just have a session or a day on its own on part of this, because I know there's a lot that goes into adaptive learning, and in the interest of time, you've been rushing over a lot of those concepts. So some of us, for the first time, you might be hearing this, and it might be too much to take in at one go. But I really appreciate this, and I just wanted to point out that it will be great if it had some of these concepts had their days where we just break them down.
Okay, got it. You are right. Got it. Okay. I can see we have guys who are dropping out also, and time is not on our side. I think we need to begin to call it a wrap. So, okay, I come at this point, I say thank you so much for listening to me. It would be nice to also to hear from your end. If you have any comments, the very last questions, and some of the answers that we can give, maybe the next 2-3 minutes, then we can call it a wrap. General comments, if at all you have. Anybody out there?
Yeah, thank you so much, Bill, for this. It's an eye opener on what comms can do beyond the normal things that we do.
Yes. This is just to let you know that we have a lot of work out there. Comms is central, comms is needed, comms is taking it right where we need to take it. And we have a lot. We have a lot beyond our newsletters. We have a lot of work to do beyond our videos. We have a lot beyond our news. We have a lot. A lot of work is out there. A lot of work. And this is what we call development communication.
Yeah. So I'll be reaching out on BCC. We had talked about this a little earlier.
Oh yeah, I remember. Oh yeah, this is Ocean.
Pardon?
Is this Ocean?
Who is
speaking, please? Oh, Lydia. Oh, okay. All right. Okay.
Yeah.
Welcome, Lydia.
Yeah, thank you.
Okay.
So, Bill, as we prepare to ask, or as we even wind up, would you be kind enough just to summarize those would want to call them strategies, or those key things that you talked about, place sensitivity, time and all that. Just summarize what we talked about for the sake of those of us who just joined in halfway, so that they know from the top what we talked about, like those the slides what they were about. And I think
I think I have one particular intro slide that that really speaks to everything that we have talked about today. If you're able to look at my slide. And sorry for the guys who are joining a little late. I know here and there, but I just want to let you know that we looked at the right messenger, and one of the things we're talking about that you could have the message, but you're not necessarily the right messenger. So you need to be very careful about what you deliver out there. The other thing we talked about was the effort sensitive. We talked about two things. There was the pay for performance, and where you actually be able to pay persons to be able to deliver some work in some context that you desire for quality that you want. And of course, we also talked about non-monetary incentives that can actually work. And then we talked about the enabling differentiated services, where you can actually be able to change your timing, just the timing alone, and discuss about timing so that you can be able to deliver different behavioral for health-seeking behavior. And then there was about location also, where are you putting all this information, which is very timely also important for this context. We talked about being able to think retooling, be sensitive to retooling. Not everybody has the skills and that kind of thing, but you can actually jumpstart other people's lives and behavior differently. And of course, now we're talking about adaptive learning. And in my life, adaptive learning has just become the new thing. That's what I was talking about. And I'm really, really scratching my fingers into everything that is called adaptive learning to learn through what is happening. Currently, I will just let you know that I'm leading a program that is actually focusing on family planning in 19 counties. And I am actually leading the adaptive learning component, which is quite exciting. So basically, this is just a nutshell of what we talked about. As I had promised, maybe another time we can now look at technology and health a bit differently, because some of the questions came from that area and how to work on it. Okay, now I want to hand over to Oyer. Thank you so much for hosting me.
Maybe just a question before you go, Bill.
Okay.
Thank you so much. That was a quite a good presentation from your end. And I think most of them are asking that in the design of the project, how did you involve the media? I think it would be nice to know how you involve both the digital and traditional media. Thank you.
Thank you so much. This must be Hezron. Thank you so much. You know, it depends with each project. All this you see, 1, 2, 3, 4, 5, 6, 7. All these are different projects. All of them are different projects. And it depends. There are projects that you can actually engage the media. There are projects that you cannot engage the media. For example, when you talk about media engagement here, I'll go to the first one where I talk about the right messenger. For the right messenger, where I played the clip of this little girl's voice and talking, because we were able to get the voice, but we were not able to use the to get it out there without radio stations. So there was a point at which we actually engaged radio stations, and I think I engaged 6 radio stations in this region to be able to reach the persons that are our target, who are young lactating mothers. And of course, that particular point, we actually engaged radio stations, and we engaged them at different levels depending on how much they were able to take on our budgets and the pays. So there was the budget management that had to be done. So at this particular point, I remember Jael Lieta, who is now an alumni here, had not joined Maseno University, but I engaged her in this assignment and in one of our radio stations, which benefited from a lot of the work that we did. Now, when you talk about performance for pay, we didn't engage the media. And non-monetary incentives, no, we didn't engage the media. That is also inclusive of the enabling differentiated services. The one that we actually engaged the media was the promotion of the PPAUD, because we needed to reach the policymakers in this region in terms of health sector. And this was basically discussions around the policy and the issues of IUDs in the facility. The retooling, we actually didn't engage the media, because we were basically looking out for how then do we place this workplace. So the media didn't come out there. Now, enabling adaptive learning for policy engagement, I have not yet engaged the media, because this is something that I want the county to adopt before this. But of course, there are many methods in which we can engage the media directly or indirectly to be able to work on this.
Thank you, Bill.
Right. Thank you, Bill. Thank you, team, for filling your time and for honoring the invite. I'm proud and I'm glad that we did this is the first one, we set the ball rolling. So that was the most important thing to do. Hezron and the team will be getting back to us on our WhatsApp group on our next program. And based on the feedback that we've gotten off this presentation, we'll also formulate if we need, other follow-up, smaller meetings or discussions around development communication, especially SBCC and its components. I'm glad that you came, and I'll just end the meeting. We'll have this recording. I'll share it tomorrow. It will be, on Google Drive, so you can download it. It's an MP4 document. Thank you.
Okay, as everybody goes, I like doing something when I do presentations. Just send me a personalized text on how you think I performed, and if there are areas of improvement you feel I should make. Thank you so much.
When you talk about text, Bill, just tell us your number or type it on the chat. What's your number? Oh, okay. Of course, it's in the WhatsApp. So please, yeah, guys, just check on the WhatsApp. Let's give Bill the feedback. Next time, we'll have a poll or a survey that will evaluate our meetings. Thank you.
Super. Thank you so much.